So the another topic we are beginning with neuro-ophthalmology second part, that is pupil and its lesions. Okay, so now we are going to discuss about the pupil and the lesions associated with the pupil. First, beginning up with the pupil reflexes. What are the reflexes of the pupil? So the pupil is under involuntary control. The pupil is under involuntary control. It is not in voluntary control that you will say to the pupil to dilate or the constrict and it will. So it is involuntary control. It is not under your control. Very simple. Now, what are the conditions under which the pupil shows reflexes? So the first condition, near reflexes, we have discussed in our later videos. So you can refer to those. In a great detail, we have discussed the accommodation, convergence and meiosis mitosis. Okay. Beginning up with ciliospinal reflexes. Ciliospinal reflex is nothing but ipsilateral, both the eyes. Ipsilateral pupil dilates due to pain on neck, face or the upper trunk. So if I pinch you, or if any sort of stimulation is given, a pain stimulation is given on the neck, face or the upper trunk, then your pupil will dilate ipsilaterally. Very easy. Now the next comes is psychosensory reflexes. Now psychosensory reflexes are dilation of the pupil in response to stress, or in any stress or a strain condition there will be a pupil dilation. Okay, and both the pupils will dilate. This is a common phenomena. Now the phenomena which we are going to discuss over here in this neuroophthalmology of pupil is light reflex. So we will discuss brief about the light reflex. Light reflex is basically of two types. What are these types? These are direct light reflexes and consensual light reflexes. Direct light reflexes and consensual light reflexes. Direct light reflexes, the name itself suggests us that the light is put on directly on the eyes. Consensual light reflexes are, in this there is a constriction of the pupil without any light source or without any light throw. Okay, so here you are throwing the light on the eyes and here you are not throwing the light of the on the eyes, then too pupil is constricting. Okay, so constriction of the pupil with light or without light. This is direct light reflex and consensory light reflex. Let us see how this pathway works of these both. So here you can see the direct light reflexes in which light is thrown and the pupil is constricting, and here you can see consensual light reflexes in which light is not thrown but then too the pupil is constricting. Very easy. Now coming up to the pathway. So beautifully you can see over here the pathway of the light reflex. Now one side we are taking consensory light reflexes and one side we are taking the direct light reflex. Okay, let us understand both the pathways. We'll discuss direct light reflexes. It is similar only. Okay, now in direct light reflexes I am throwing the light. I'm throwing the light on the eyes. Which eye is this? This is the right eye. Okay, so I'm directly throwing the light on the right eye. Now what is going to happen? There is something called as the optic nerve and we have discussed it in a brief detail. Okay, this optic nerve takes the sensation and then gives it to the optic tract. After giving this sensation to the optic tract, this optic nerve doesn't travels in the optic tract and crosses it and comes out. and forms the pupillomotor fiber. It forms the pupillomotor fiber. And what is this? This is nothing but the leaving of the optic nerve before it relays the LGB. Very simple. Now, when this pupillomotor fiber has came out, it is going to the pretectal nuclei. Okay. And this pretectal nucleus, what is this? This is the center of the light reflex, which is situated at the level of superior calculus. Very simple. Further, it will transmit the sensations to the internuncial neuron. It is going to transmit the sensation to the internuncial neuron. Nuncial means nothing but the nucleus. This internuncial neuron is again transmitting it to a very important structure that is known as Edinger-Westphal neuron. This, and it further transfers. You can see over here the yellow marking over here. This yellowish thing is nothing but the internuncial neuron, and this internuncial neurons are going both the side, you can see over here also and here also. So it is traveling in this also and it is traveling in this also. Then these sensations are carried out by the ophthalmic nerve. This greenish color that you can see, this is ophthalmic nerve, which goes to the ciliary ganglion, and ultimately this ciliary ganglion is going to the short ciliary nerve, and your pupil is going to constrict. So this was all about this. What are the afferent nerves and the efferent nerves? The afferent nerve is the optic nerve and the efferent nerve is the oculomotor nerve. As you can see over here, this optic nerve is the afferent nerve and the oculomotor nerve is the efferent nerve. Now directly coming up to the important topic, that is pupillary abnormalities. What are the pupillary abnormalities associated? The first comes in the afferent pathway defect. The afferent pathway defect, okay. This afferent pathway defect, or called as APD. The first in the afferent pathway defects comes is the absolute afferent pathway defect, or you can say it as a total afferent pathway defect, or it could be also named as amoretic pupil. Now the name itself tells us absolute or the total pathway afferent defect is nothing but the complete optic nerve is damaged, because as we discussed, the optic nerve is the afferent nerve. Very simple. So assuming that the lesion is in the right optic nerve, so let's take an example that the lesion is at the right optic nerve, this one. Then what is going to happen? So the first possibility could be that if the both eye pupil constrict and both are getting into the equal size after the constriction, then this is known as isochoria. Very simple. Now another possibility. Now when we put the light on the left side, as our lesion is at the right side, the lesion is at the right side, the abnormality is at the right side, we are putting the light at the normal side, at the left eye. Then both the pupil are going to constrict, the normal phenomena also called as isochoria. But when we throw the light on the right eye, which has the abnormality, there would be seen no react. The pupil would not react of the right eye, or it will remain constricted. Okay, and you can see mild dilation, also isochoria. Very simple. So in such a condition, when you have a AAPD, okay, there is a ipsilateral direct light reflex absent, and even the contralateral consensual light reflex is also absent. And there is ipsilateral anopia, and even the patient will suffer from near reflex absence. Very easy. So that was all about absolute afferent pathway defect. Now coming up to relative afferent pathway defect. Okay, also called as Marcus Gun pupil. Okay, and this is a partial optic nerve lesion. This is a partial optic nerve lesion. Only the part of the optic nerve is damaged. It includes what all can lead to this partial optic nerve lesion. These are optic neuritis, retinal detachment, central retinal arterial occlusion, and central retinal vein occlusion. These are the four conditions which can lead to the partial optic nerve lesion. Starting it. So assuming that the lesion is in the right optic nerve, and the lesion is partial, remember the lesion is partial and it is in the right optic nerve, the left one is normal. Okay, now so in such a condition both the pupil are constricted, both are in the normal condition now, so this is known as isochoria, obviously. Now we are throwing light on the left one, which is the normal one. Okay, so both the pupil will constrict, isochoria, simple. But when we will throw light on the right eye where there is a lesion, then it is tested by swinging flashlight test. Okay, swinging flashlight test, and this leads to the fatigue of the partial lesion optic nerve. Fatigue of the partial lesion of the optic nerve, which leads to. So leave the theory part. Let us discuss this thing with the help of a beautiful diagram. Let us see that. So here is the diagram clearing up all your theory part of this lesion. What is happening over here is very simple, that this is your right eye and this is your left eye. What I am going to do in this test called as flashlight test. So in this swing flashlight test, what I am going to do, I am just going to swing the flashlight from one eye to the another eye. Okay, so again and again I'm going to swing this light from one eye to the another eye. Why I am doing this thing? I'm doing this thing because the right side optic nerve is partially damaged or having an abnormality, due to which it will get fatigue very early when I'll do this swinging of the light. Okay, it will get fatigued very early, due to which what is going to happen, when I am going to throw the light on the left eye, which is normal, the pupils are going to be constricted. When I am taking the light away, then the pupil in this stage dilates up. When I go to the abnormal eye, after the pupil gets fatigued in the right eye, after the pupil gets fatigued in the right eye, what is going to happen? this was undergoing a dilation process. Okay, the pupils were undergoing a dilation process. But as soon after the fatigueness of the right pupil, I took this torch or a light source and I embedded the lights on this right eye. Then also I can see, due to fatigueness, what is happening. These eyes, the right eye is undergoing dilation even after embedding the light on the right eye. So this is a test. So I took the light source, I embedded the lights on the right eye, which is a lesioned eye. Okay, the pupil got constricted. Very easy. Then after swing flash test, I made the right eye getting fatigue. I made the right eye to get fatigue. Okay, the pupils of the right eye got fatigued. After this fatigueness, when I am going to do the swing test again, then due to this fatigueness, what will happen? The dilation would occur, not the constriction. Okay, the dilation is going to occur, not the constriction is going to take place. Okay, so this is a very simple test, and this dilation, due to the fatigueness, dilation is going to occur, not the constrictness. So this dilation, this phenomena is known as paradoxical dilation or pupillary escape phenomena. Very easy and very important. So this is all about your paradox dilation, and this completes your relative afferent pathway defect. Now coming up to Wernicke's hemianopia pupil, the third lesion, and the site of the lesion is in the optic nerve again. Okay, and in which light reflexes, there is a field defect, there is a visual field defect now. Okay, that we studied in the previous videos, again discussing it. So if there is a optic tract defect or optic tract lesion, the optic tract is going to get injured, due to which the pupils are not going to contract. Okay, so the first condition in which I am throwing light on any of the eye, okay, from the side, from a side, from a particular side I am throwing the light, and there is no vision, there is a visual loss. Another thing, when I am going to throw the light on any eye from a particular side, the vision is present over here, and this, due to this, here the pupil is going to constrict. Okay, so this side there was no constriction, and here there is constriction. The next comes is the afferent pathway defect. The afferent pathway defect, we studied about the afferent, now we are going to efferent pathway defect. Efferent pathway defect, the first comes is the Ergil-Robinson's pupil. Ergil-Robinson's pupil, how is it caused? So the causes, the most common cause of Ergil-Robinson's pupil is neurosyphilis, or known as tertiary syphilis. Very important cause. Another is Tapes dorsalis. Another is aortic regurgitation. These are the three causes of Ergil-Robinson's pupil. Now the site injured or the site involved in this defect is rostral midbrain, or you can say it as aqueductal gray matter. The posterior commissure is involved. Now what are the clinical features of Ergil-Robinson's pupil? The first clinical feature over here is the pupil does not react the or does not reach the light. So the pupil is not reacting, and this is known as LR absent. This is light reflex absent. Very easy. Now the near reflex is present. When there is a near reflex, this is near reflex present. Okay, so the light reflex is absent and the near reflex is present. These are the two clinical features. Then coming up to the, so here is a mnemonic for this, that is ARP, and the opposite of it PRA. Okay, what is this ARP and PRA? So this is accommodation reflex present and the pupil reflex is absent. Okay, now the clinical features also include that the pupil does not constrict by the use of pilocarpine and does not dilate with the help of atropine therapies. Okay, and the fourth thing coming is that the pupil is always seen constricted, and this is meiosis. Okay, and due to the lesion, the rostral midbrain is also damaged, which supranuclear inhibitory fibers of Ellingar-Winsel's nuclei, these these keep on releasing the parasympathetic impulses, due to which there is a pupil constriction. Okay, and we say pupil does not dilate in dark due to this phenomena. So that was all about the topic. Now in the next session we are going to start the another part of neuro-ophthalmology, that is optic atrophy. Very important. Color blindness, very important, and some miscellaneous things. Okay, thank you.